All right. Well, the old atomic clock says it's 6:02. We're supposed to start at 6, so I can't be like I was in clinic today. Can't be behind. So let's get going. All right. Well, welcome everybody. I'm Dr. Rumley. I'm emceeing this tonight. I'm an orthopedic spine surgeon at the Center for Spine and Orthopedics. I'd like to welcome everybody on behalf of all of our physicians. Tonight's CME lecture is going to be run by Dr. Noel, who's an orthopedic sports surgeon specialist in our clinic. This is our sixth and last virtual CME lecture of 2021. We have them planned to be doing them in 2022, so I hope nobody's too sad. We will be sending likely alcohol and snacks out next year as well. We'd like to thank everybody who's joined us for the previous lectures, and for any of you that this is your first lecture, welcome. It should be fun. I'd also like to thank Health Images. They've been co-sponsoring all of these, and without them, I certainly don't think we'd be able to do this. And especially Dr. Sana, one of the radiologists that I know I work with a lot. He's a phenomenal orthopedic, musculoskeletal, and spine radiologist. He was there for Dr. Coleman's lecture and did such a great job with that we've asked him to come back and talk some more. And he's going to, after Dr. Noel's lecture, do a talk on imaging of hip arthritis, which I think is going to be super helpful. And I'm looking forward to hearing that part as well. So a little bit about Dr. Noel. So Dr. Noel specializes in sports medicine, arthroscopic surgery, total hip and knee surgery, shoulder replacements, general orthopedics, and orthopedic trauma care. So essentially everything. He joined our practice in 2019 after completing a sports medicine fellowship at Cincinnati Sports Medicine. Probably the biggest name out of there is Dr. Noyes, who actually wrote a book called The Knee, right? Is that right, Oscar? The knee book, or the knee?
Yeah, the Bible.
Yep, the knee Bible. So pretty wonderful experience. He also, while he was there, got to work with the team physician for the Bengals and had on-field coverage experience for the MLS soccer team, football club, Cincinnati. Pretty lame name. Previously, Dr. Noel performed research in St. Louis, Missouri with Dr. Leo Whitesides, who is arguably the biggest name in arthroplasty in world literature. Certainly, I read most of his papers going through my residency. He also completed internship and orthopedic residency at DePere, spelled DESPERES in case anybody's looking for his credentials, but it's in St. Louis, so they say it very French-like. He got good orthopedic trauma experience at St. Louis University, one of the top trauma hospitals in the country. Originally, Dr. Noel is from Colorado, and he completed medical school and anatomy fellowship at Rocky Vista University, the osteopathic school in Parker, Colorado. And he was actually there when I was rotating through here. And sadly, we probably ran into each other, but we didn't know each other. So Dr. Noel is the fourth orthopedic surgeon in his family, which is pretty amazing. He's got a lineage. Orthopedics is in his DNA. He takes pride in taking care of patients and believes in personalized care and shared decision-making, which I think is one of the hallmarks of this Center for Spine and Orthopedics clinic. He does his best to make patients feel comfortable and fully informed so that they can make the best decision. I've never had a patient who Dr. Noel's seen that's come and seen me that said, he told me that I have no choice, I have to do this. Every single one of them said he listed all my options, he went over it, and he explained to me what he recommends, which is increasingly uncommon in modern medicine. So his Christian faith is extremely important part of his life and an integral part of his practice philosophy to always do the right thing for his patients. Dr. Noel's wife and two daughters enjoy living in Colorado and all it has to offer. And they're frequently doing as much hiking, skiing, golfing, tennis, hunting, and fishing as his schedule will allow for, which isn't as much as I'm sure they would all like.
And they're a little small, so you know.
Yeah, his newborn baby does not do a lot of hunting. I'm very sure of that. But before Dr. Noel's lecture, I'd like to first introduce Dr. Downs, our SOM. Anybody who's been here before knows that he's a wonderful speaker and knows more about this than I know about OB-GYN, and he knows about both because he specializes as an infertility physician and OB-GYN physician. He's been the SOM for over 5 years, an event planner at Wyatt's White Goods in Longmont, which is a wonderful location, and I personally shop there almost primarily. He became interested in wine during his years as a physician and has now become an absolute expert on it. So I'd like to introduce Dr. Downs to lead the wine pairing.
Good evening. Happy to be here tonight. I'm looking forward to this lecture. I myself had a hip replacement about 3 or 4 years ago. I had a bilateral hip replacement, anterior approach, and I was back to work in 10 days. So I'm looking forward to hearing this talk tonight. Tonight I have 4 beers and I have a great wine. The beers I chose this time I'm calling Kevin's All-Stars. They're basically 4 beers that were really popular with my events this summer. I did about 100.
Might have lost you there.
Well, the All-Stars look great. Unfortunately, we can't hear Dr. Downs.
We lost him completely.
I drank them before. They're wonderful. I think he might be back. Hold on one second. We have some problems with the conference room stuff. See if he's. All right, Oscar. We'll maybe have to. Yeah, well, maybe I have to finish that after your portion of the talk.
Let's talk about anterior hip replacement, and then we can talk about the bruise after, unless he clicks on here in the next 5 seconds. You want me to wait? You want me to just go?
I would say go. The only problem is once we start, you have to complete all the CME portion before we talk about alcohol. Because as much as we all view our alcohol as an important part of our practice, after practice, we can't include it in the educational portion.
I'm gonna give him about 10 more seconds, everybody.
We have Dr. Downs back.
Okay.
Sorry for the technical difficulties, everyone. May be experiencing solar flares in the area.
You guys seeing my screen or theirs?
We can see your screen.
There we go. You're back, Dr. Downs.
So shall I resume or?
Yes, sir.
Okay, as I started to say, sorry about that interruption. First beer is Prost Pilsner. It's a German style Pilsner made by this great brewery in Denver. They use German hops, and they also use a yeast that's fresh out of a German monastery. So it's very authentic. It's got an ABV of 4.6, so it's just real easy drinking. It's my customer's favorite Pilsner. Next is more of a summertime beer. We're getting out of that season, but one of the great summer porch pounders is Dry Dock Apricot Blonde. Dry Dock is up in Fort Collins. They do a great job with all their beers. Their Apricot Blonde is a blonde ale, and they actually ferment it with an apricot puree. And it just is very crisp, light, easy drinking beer, just the right amount of apricot. It's about 5% ABV, so it's just a great porch pounder, as I say, for the summer. Next is the Avery White Rascal. Avery's a great brewery here in the area. The White Rascal is a Belgian-style wheat, and it's spiced with a bit of coriander and orange peel. Very lightly done, very great beer. Again, an ABV of 5.6 and just a bit of hop. It's about 20 international bitter units. Finally, we always have to have an IPA for the hop heads. So I picked Odell Mountain Standard. It's a really popular beer from Odell. Odell's a great brewery. They use American style hops. It gives these kind of tropical hop aromas of kind of pineapple, orange, maybe a little mango in there. It's triple dry hop that it basically accentuates the aromas. Really bright hop flavors, very low bitterness. It's only 40 IBU, which is not a very high level of hops. So it's very pleasant and easy to drink, about 6.5 ABV. So it's not quite a session IPA, but not real high in alcohol. So these beers are great. There's lots of great beers out there, obviously, but these are just 4 that I like. As far as our wine tonight, I picked probably my favorite grape. Tonight we're talking about Nebbiolo. Nebbiolo is a grape that's grown almost exclusively in Piedmont in northern Italy. It's incredibly terroir expressive, which means if you grow it in Piedmont, it tastes like Nebbiolo usually tastes. If you grow it in California, you have no idea what you're drinking. If you grow it in New Zealand, you have no idea what you're drinking. It's very, very, very specific for Piedmont. In fact, it doesn't even grow anywhere else in Italy. I like to call it the little grape that could, because when you pour it in your glass, it's pretty well translucent. It looks almost like Pinot Noir. It's very light, but then when you smell it and when you taste it, you're blown away by the strength of the flavor, the support from the tannins, fairly high acidity. It makes it one of the greatest food wines on the planet. This is the grape that the great Barolos and Barbarescos are made from. They usually start at $40 a bottle and go up to a ridiculous amount of money. But these are the most age-worthy wines you can get in all of Italy, and one of the most age-worthy in the world. These will sit, a good vintage, these will sit for 20, 30 years in your cellar before they reach full maturity. Tends to have aromas of kind of the classic aromas of the great Barolos are tar and roses. This is a Langhe Nebbiolo, which means a Nebbiolo that's not from Barolo or Barbaresco or one of the real Grand Crus. This has got that rose petal on the nose, a little bit of anise and lots of red fruit. Flavors, you get cherries, you get a little coffee, you get a little anise, great tannin, great acidity, again, making it a wonderful food wine. So enjoy the little wine that could, and with your next ribeye, pour one of these babies. Thank you very much.
All right, thank you. All right, Oscar, now let's hear about some anterior total hips.
Sounds good. All righty, so tonight's lecture is about hip arthritis and the anterior approach to hip arthroplasty. For those who are present at my total knee lecture about 2 years ago before COVID, these share a lot of similarities, but we're going to kind of touch on what's more hip than knee. So disclosures, I don't have anything to disclose. I don't have any associations or get money from anybody, unfortunately. So maybe someday. The learning objective tonight is, to recognize hip arthritis as the problem. And we're going to include in that some differentials in the exam that was brought to my attention. What is it? Display setting. Oh, okay. Sorry about that. One of the attendees tonight is a primary care physician who really wanted us to kind of touch on what the exam and differentials are for hip arthritis. And it's nice that our MC tonight is a spine surgeon, because that is one of the very, very important things not to forget in a hip exam is there's kind of a spine hip syndrome, and you got to figure out what the problem is. And with just a little bit of discussion, I think everyone in attendance can kind of narrow it down to a good degree. And then we want to talk about the non-operative versus surgical treatments for hip arthritis and how you optimize a patient for joint arthroplasty, and then explain the use of the anterior hip approach in the anatomy that's associated with the anterior approach, and what the benefits are of using this kind of newer approach, although it's been around for a while. There's a lot of approaches to total hip replacement, and they all have their benefits and they all have their downsides. But the anterior approach is something that's kind of new and upcoming. And as you heard Dr. Downs say, he had bilateral anterior total hips. One of our providers here at our office had an anterior total hip. And you listen to these patients talk about their experience, and I assure you it's something that you'd be interested in. So the presentation of hip arthritis, you're going to have, obviously you're going to take a history. You're going to have a lot of things that will, before you even walk in the room, that you may have a differential that this patient has arthritis. And the symptoms really are going to help you a ton. You got hip pain, you have groin pain, you have decreased ability to walk long distances. They have hip stiffness. Questions I ask if they have trouble tying their shoes or trimming their toenails. Those are things that people really complain about. They can't sit Indian style. They can't get in certain positions, and it's because there's a mechanical block to their hip. They can have pain at night or with rest, and they can have locking and catching sensations. That is also very common. Just some, slides that we can kind of breeze through here, but to know that, knee arthritis is at least 3 times as prevalent as hip arthritis. Your risk factors are, modifiable and non-modifiable. If you have trauma to the hip, certain muscle weaknesses, which can come from the back, or leg length discrepancies or nerve damage or things like that, can increase stresses across the hip and cause arthritic change. Heavy physical stresses at work can do that, but not to the same degree. And then high impact sporting activities, obviously in healthy cartilage, impact exercise is not necessarily a big problem, but anytime you start having some degeneration, impact exercises can really speed up the process of degeneration. Then there's non-modifiable factors, more common in females. There's a high genetic relation with arthritis in the hip, knee, in the back, all kinds of areas. And then there's developmental or acquired deformities, whether it's dysplasia, a SCFE, or leg calf perthes. Somebody develops AVN, from whether it's steroid use, or maybe they're a deep sea diver like Dr. Jansen or somebody like that, come up too quick. You can get something called Caseyon's disease, and you can have AVN in your hip. And before you know it, you're getting an anterior hip. So some of the, Patho Anatomy, there's cartilage that degrades, you have increased water content and a decrease in your proteoglycans, and then you get cartilage abnormality or collagen abnormalities. This is stuff, I'm sorry, that not everybody is super interested in, but it's important to know that this is kind of a cascade effect of inflammation that starts this degradation, that you have an early and middle and late phase, where early phases can be very painful. You see patients that don't have bad x-rays, and Dr. Sana can probably talk about that a little bit later, where you have more inflammation in the synovium, and the synovium becomes inflamed, and you get more joint fluid, you get distension of the capsule, you get this aching pain deep in the joint. And then as your inflammatory changes become more advanced, you get hypervascular synovium, and then you start having some effects on the cartilage and bone. As cartilage starts to crack and degrade and fissure, then it starts flaking off. You get subchondral bone that starts seeing increased joint reactive forces and starts to try to remodel. Then you get lytic changes, sclerotic changes. And then in the late stages, you start getting bone cysts. There's a lot of things that are associated with this inflammatory cascade. There's MMPs and TIMPs. This is just inflammatory type things that are associated with arthritis, whether it's knee, hip, shoulder. And so anti-inflammatory is great for arthritic related things. Inheritance, it can be non-Mendelian. There's a lot of genetics linked with all types of arthritis, vitamin D receptors, estrogen receptors, inflammatory cytokines, and some of our BMPs type stuff. So kind of getting through the eye-rolling, nauseating part of arthritis into the differentials. So someone comes in, you're like, wow, I wonder if they have hip arthritis. Well, what else could it be? You know, you got to ask them, did they have an injury or no injury? Is it just muscle contusion? Is it a muscle strain? In a young patient, is it kind of some pubalgia? Do they have a strain to their anterior hip muscles? Is it piriformis syndrome? My patients with arthritis classically complain of kind of a C-shaped pain around their hip, really concentrated at the groin. If somebody's saying that it's right in their butt, back in their gluteal region, you know, think about piriformis syndrome. There's some specific exams you can do from that. Tight hamstrings can pull down on your ischium and cause the pelvis to rock forward or backwards and cause a lot of strain on the lumbar muscles and tendons back there, as well as your SI joints. And that I can't tell you how many patients I see with hip pain, and it's really their low back or their SI joint region. There's a lot of inflammatory disorders, whether it's tendonitis, rheumatoid, things like that. If they're complaining of snapping in their hip, or I feel like my hip dislocates, doctor, my hip always is dislocating. Well, a native hip, I can tell you, is probably not dislocating. It is a highly concentric joint unless you have some weird dysplasia, and a snapping hip, an external snapping hip like your IT band or iliopsoas snapping, can give the uninformed patient the idea that their hip is dislocating. Hip bursitis is incredibly common, driven by tight IT bands, hamstrings, things like that. It's like rubbing two sticks together. You got your abductor musculature and your IT band and your TFL rubbing over your greater trochanter, and you get that bursa all inflamed. And that's usually an anti-inflammatory injection and therapy solution. Can be arthritis. Maybe it's not arthritis of the hip. Maybe you got arthritis of the SI joint. Maybe you have degenerative facet disease. It could be septic arthritis. You know, somebody's been sick recently and all of a sudden they've got a really painful hip. They can't move it. They can't walk on it. That's more common in children, but you know, it's not out of the picture. Avascular necrosis. We talked a little bit about that. You'll start seeing head collapse. Dr. Sana may be able to touch on that a little bit. I don't know if that's part of his lecture, but you know, people that use chronic steroids, whether they're asthmatics or they keep getting steroid packs or whatever, they can have, that's probably the number one I see. There's idiopathic, there's, you know, specific types of chronic illnesses that can lead to that. And those patients are acutely present to your clinic with severe pain, and x-rays will often show some collapse of the head. Those patients are soon for a joint replacement. Labral tears are another thing that can cause a lot of hip pain. These are usually your younger patients, ones that can be fixed. Older patients is usually a degenerative process. Labral tears are typically, you can figure those out based on history and exam, whether you're doing a hip scour or a labral stress and shear exam, complaining of clicking or popping deep in their joint. And then if you have high quality MRI, you can sometimes see those, or you get an MR arthrogram. Hip fractures, you can have hip pain, groin pain from a non-displaced femoral neck fracture or stress fracture. So always keep your eyes out for that. We talked about a little bit about hip dislocations, tumors, not uncommon in the proximal femur. A lot of benign tumors in older patients, unless it's a metastatic lesion. Can be chondral defects, which, you know, whether that's associated with a labral tear, a delamination type of thing from an injury, or is the chondral defect, you know, part of the degenerative process. You can have injuries to the surrounding capsular structures or the ligamentum teres. It could be sciatica, nerve irritation, any kind of capsular disorder, or just ligament strain. So there's kind of a huge long list. The exam. So usually an arthritis exam is pretty straightforward. There's not a crazy exam like, you know, for a young patient, athletic knee or a shoulder exam. Really, you just kind of want to look at them is the first thing you want to do. You just want to look at it. You look at their body habitus, you look at their gait, check their leg lengths, look at their skin. You know, leg length inequality is big, and it's something we can actually address with hip arthroplasty to a small degree. Skin's important to look at. You know, you get caught off guard. People got a lot of pain, and all of a sudden they got like zoster or something like that. You got to really look at your patients. Range of motion is probably the number one thing that's going to tell you if they have hip arthritis. If they have some lack of extension or flexion of their hip, and especially limited internal rotation and painful internal rotation, you can almost guarantee you get the diagnosis every time. I saw one in the clinic yesterday. He's like, yeah, my hip's kind of hurting too. And I was seeing him for his knee, and I took his hip and internally rotated it, and he only had about 5 degrees of internal rotation. And I checked the other side with him sitting on the edge of the bed, and he had about 30 degrees of internal rotation. And there you go. I knew he had hip arthritis before I got the x-rays. Someone is writing on my slides. I don't know if you guys can see that. You want to palpate as well. You can really find, you know, iliopsoas tenderness. You can feel hernias if you're really looking for that, and troch bursitis, which is also very important. Strength testing, special tests. You know, I typically lay a patient back and do a log roll. I do a straight leg raise. I drop them into Faber figure 4. I do a hip scour, which is where you flex them up and you internally, externally rotate them. And then you can do Ober's test to really look for tight IT bands. You want to do a distal neurovascular exam, and don't forget your lumbar exam. Dr. Rumley can probably give his input on this. It is very, very important that you figure out whether it is lumbar, is it hip, or is it both. So can you guys see that those red lines on the screen?
Yeah, your screen's a little bit off center, by the way, your presentation. It's kind of like a left alignment.
Interesting. I'm not sure how to share that, but somebody drew some red lines on my slides and I can't get rid of them. Anyways, Xray findings. So Dr. Sana would be a great person to talk about this. Osteoarthritis of the hip, you're going to see joint space narrowing, osteophytes, subchondral sclerosis, which is increased, you know, density of the bone, and sclerosis is kind of like increased white around the joint, and subchondral cyst formation in the later stages. Pelvic obliquity can be secondary to spinal deformity or leg length issues, and that's something to pick up on your x-rays. Acetabular retroversion is not super important for, you know, when we're talking about hip replacement. I mean, we can change the position of the acetabular cup, but if they have bad retroversion, it can make it more difficult. You have to take down more bone spurs. You got to get yourself centered. And again, if somebody's used to retroversion or a severe anaversion of their acetabulum, a lot of times their capsular structures and muscles are used to that. And so you got to be careful that you don't have an instability issue. So here's some x-rays that I've taken as a patient that Dr. Rumley has recently referred to me. You can see that his right hip is severely degenerative. And can you see this on my screen? Somebody wrote a bunch of red lines on there.
I don't even know how that could have happened.
I don't either. It said Doran did it. I don't know who's Doran. Don't write on my screen, Doran.
Hey, Oscar, do you think you can exit out real quick, then reopen it? Maybe that'll.
Let me try, because that is driving me insane. Hold on, guys.
I'm gonna pause your camera.
There's nothing worse than orthopedic surgeons that have problems with their x-rays. It's
Yeah.
Maybe worse for Dr. Santa, but for me, it's.
I hate bad imaging. Huge pet peeve.
I mean, because orthopedic surgeons can't read. So the letters, it was fine to be covered, but the images, that's where we draw the line.
Looks great.
Super. Okay. Sorry about that. Some technical difficulties. So this is a patient that recently was referred to me by Dr. Rumley. Guy's got bilateral hip arthritis. You can tell that there's some dysplasia and severe degeneration of the right hip. He's gotten some flattening and widening of the head, some subchondral sclerosis and cyst formation, and some widening of the acetabular opening, and some pincer and cam lesion type stuff. I mean, it's very advanced. Left hip as well, severe arthritis, very minimal bone space or joint space remaining. This is someone that's probably close to getting bilateral total hips. It's really nice, our software and technology these days. You can take these programs and you can use your vendor specific type stuff and template what you're going to need. It helps you figure out what implants you're probably going to be using in the OR. So you can see there in the right panel, the stem I've selected, the size I've selected, the position of the cup, and it can give me some really good information that I can look at before I go in the OR and know what I'm doing to make the best outcome for the patient. So my views, there's a lot of X-ray views you can get of all types of structures. You can get lots of obliques, which are my favorite when X-ray takes nice obliques that aren't perfect. But I usually get a standing AP pelvis, get an AP hip, and a frog leg lateral. If you really want, there's a false profile view that you can get, but that's not my standard. This is another patient of mine that was referred to me recently that has severe collapse of her left femoral head. And severe arthritis. So we'll get back to her later in the case. So things that you're looking for joint space narrowing up there up top, osteophyte formation, subchondral cyst formation. You can get lots and lots of cysts forming off the head. You see this increased sclerosis there. Osteophytes can form off the head. They can form off the acetabulum. They can form down off the bottom. And there's just some different levels of arthritis here. Here's this in the left panel and picture. There's a subchondral cyst in the superior acetabular dome. So non-op treatment. With all arthritis, I tell patients that they should do non-operative treatment for as long as possible, as long as they're not completely miserable. You can have benign neglect or observation. Anti-inflammatories, tramadol, are great for people with arthritis. Actually, a cane or a walking stick can actually decrease joint reactive forces and help patients with arthritis significantly. Weight loss is an important factor. It's about a 5-to-1 conversion in the hip for how much weight 1 pound above is compared to the hip. Therapy can be important. That's really in helping regain some strength. When you're in a horrible arthritis condition, the motion's not really probably going to get much better. But patients, I think George and some of the therapists are on the call. They can tell you that these patients can really, a lot of them are in a lot of pain. If you can get their pain down with an injection, which is the next thing on there, and they get into some therapy, build their muscle strength, they actually do really, really well. Activity modification is important. You know, I see a lot of young patients with arthritis, and a lot of these people still want to run and jump and beat on their joints. And when you have arthritis, not a good thing. Injections are extremely important in hip arthritis, especially if you have any question that maybe it's their back. I tell every patient, unless it's absolutely severe, they should at least try 1 injection. If I have any question whether it's their hip versus their back, I'll have them get an injection. And that needs to usually be done under ultrasound. I'm not good enough just to stick it in there without. And so the injection is therapeutic because there's steroid in it, and diagnostic because there's numbing medication. And so I tell patients to make a diary, have certain positions that are hip, certain things that they do that really, really give them a lot of pain. Write that down on a piece of paper. In the first couple hours after their injection, while the numbing medication is still working, have them go do those exact same things and then write down a number again. If they sit Indian style and their pain is a 10 out of 10 in their hip and groin, and they get an injection and their pain is a 2, well, they got 80% improvement in their pain, and 80% of that is coming from the joint. And that's how they should, make their choice if they want to go forward with a hip replacement in the future, because that's what they should expect. What if they only get, they drop their pain down to an 8 or a 9? Well, maybe only 10 or 20% of it's coming from the joint. And things can be extra articular, but maybe you ought to be looking at the back or somewhere else. There's also some alternative treatments, holistic treatments, acupuncture, patients taking glucosamine chondroitin, not a bad thing to try. Viscosupplementation and PRP, not well documented in the literature, but if people have the finances to do PRP and they want to do that, I highly recommend it. So when is it time to get a total hip? And I tell patients when conservative treatments fail, when injections don't last more than about 3 to 6 months, their quality of life is affected. They can't go enjoy time with their children or their grandchildren or great-grandchildren. They can't do ADLs. They can't walk around the grocery store. They're avoiding tasks because their hip hurts. They can't go outside. They can't do anything they want to do. They're just sitting inside, just wasting away. It's time to get a hip replacement. There's specific deformities where I encourage patients to get it quicker. Like some of those previous x-rays you saw, AVN, head collapse, those patients are typically miserable, and we want to get them taken care of ASAP. So risk and benefits of a total hip, there's always a risk with the surgery, and that doesn't matter, if we're talking about Charcot, like with Dr. Coleman, or talking about spine stuff or shoulder stuff with Dr. Schnell, risk of surgery. Anytime you cut skin, you're at risk of infection, bleeding, wound problems, lower extremity surgery, a risk of clots in the legs or lungs, numbness, specifically with an anterior approach, you have a risk of the lateral femoral cutaneous nerve, so they can have lateral thigh numbness. Most of the time it goes away. Some of the other approaches, other nerves are at risk, such as sciatic, femoral, things like that. Leg swelling, component failure, loosening with hips specifically, dislocations, leg length discrepancy, fractures, whether it's intraoperative or postoperative. We are taking a broach and a femoral stem most of the time that is press fit and jamming it down that canal. If you hit it too hard or you fail to recognize the quality of bone, you can cause an intraoperative fracture. Somebody falls and something happens, you can have a post-op fracture. We will show you that in just a second. Ongoing pain, there is no guarantee that a hip replacement is going to get rid of all your pain. Total knees, satisfaction rate is somewhere around 80%. So 1 in 5 may be dissatisfied with a total knee. I think that we're doing better with that these days. But as far as a total hip, it's one of the most successful surgeries in orthopedics. Satisfaction rates over 90%. There are also medical and anesthesia risks. That's why it's so important for preoperative optimization to lower those risks. The benefits, obviously pain relief, improved quality of life, the ability for patients to be active again, and there's a lot of benefit to that. So talking about the risks, this is one of my patients in the left panel with the zipper. This guy, this is actually a hemiarthroplasty, but he fell after surgery, jammed his stem down the canal and wedged it open and blew out his lateral cortex. You also see a cable around that. That was placed at the time of surgery, not because I fractured his calcar, but because he had a split going down there. And so I put that on there prophylactically. This fall was 10 weeks or so after surgery. So that wasn't a fracture that just happened immediate post-op. Other panel, I take trauma call over at North Suburban. This is one of my patients that fell and had a horrible periprosthetic fracture. And that is obviously something that needs revision. The guy in the other panel with the zipper, he got by just fine with no intervention. So optimizing for total hip, any joint, any surgery, patients should probably be optimized. Weight loss, BMI, if you're greater than a 40 BMI, you're at a significantly increased risk of a perioperative complication, whether that's infection, wound problems, any of these kind of things. I like for their blood glucose to be under 8. Around 8 is good. When they're in the 9s and 10s, they can be at a significant increased risk of perioperative infection, wound healing problems, all kinds of things. Albumin, prealbumin are very important too. You want to make sure that these people aren't malnourished so they can't heal a wound. Smoking cessation is something I try to talk to all patients about, whether you're a therapist or primary care. We should all be trying to optimize our patients and get them to quit smoking. But smoking can inhibit the very small vessels, the very capillary level, and inhibit wound healing. So I try to get patients to cut back as much as possible. Prehab for total knees and sports surgeries and things like that is important. I'm not really sure about that for total hips. I'm not aware of any literature to show that therapy prior to a total hip will make a lot of difference. Most of the time when people are ready for a total hip, they're absolutely miserable, so they're not really wanting to do a lot of prehab. Patient education is key in surgery and in the medical practice. Is patients need to have a good idea of what's going on. There's a lot of miseducation out there. There's a lot of patients that just don't know anything about their health, and you just got to kind of figure out what their education level is and talk to them in a way that they can understand, and consistently ask if they understand, have them repeat things so that they're educated. And I'm always available for my patients, whether it's pre, post, anywhere between, to answer questions for them and their family. I think that's really important. Blood loss management is crucial. I mean, back in the day, people used to donate blood for joint arthroplasty. I will tell you, with an anterior approach, my typical blood loss is somewhere around 50 milliliters, if not less. That is my perceived amount of blood loss, and many studies have shown that is wrong. But I will tell you that the amount of blood loss I have with a total hip is got to be at least 20% of what a total knee is typically, if not less. Pain control is important. Typically with joint arthroplasty, people are putting people on opioids. There is a large push with anterior total hips for patients to go home with no narcotics, and they will go home with Tylenol and anti-inflammatories, whether that's Advil or Aleve. I send patients home frequently with just tramadol and ibuprofen. Some other patients, I'll give them one script of a narcotic pain medicine just in case they have a bad time. It's not infrequent that I have patients come to me and say, well, I didn't use any of it. So, and post-op antibiotics, there have been some recent literature to show that patients are at risk, they're diabetic, they have a higher A1C, or they're obese, may benefit from actually post-operative oral antibiotics going home. But other than that, we have what's called a skip protocol, where you give patients antibiotics for typically 24 hours after surgery. So we talked about obesity. You want to try to get that down as much as you can. People that are obese or overweight can have significantly increased risk, over 40%, compared to normal patients of normal weight. Again, the patient outcome education, the effect on outcomes is, kind of unknown. It's easy to do, and I truly believe that setting patient expectations and educating them can give you a better outcome, because patients know what to expect. And when I was a resident, we would tell patients they'd be in the hospital after a total hip for about 3 days. Those patients were all in the hospital for 3 days. I now tell patients they're going home the same day or the next day. And the vast majority of my patients go home the next day. Younger, healthier patients, I will do them as an outpatient, and they actually do well. I did a 40-year-old guy, did both his hips. He went home 3 hours after surgery both times. So patients' expectations, I mean, we're in an age where people expect the best. People want a short recovery. They want no post-operative discomfort. I think that's an American way. I mean, in some of the foreign countries, they don't have pain medicine. People expect for surgery to hurt. I think that is a kind of a first world problem for people to expect no pain. They don't want complications. They want better mobility and function and long-term durability, and they do not want limitations. And I will tell you that an anterior total hip, a lot of these things you can meet those expectations. So yeah, that's kind of what we talked about. So can people go back to this kind of stuff? Can they go back to skiing? Can they go back to athletic activities? I would tell you that a lot of these patients can. I would not recommend a lot of impact type exercises, but there's the consequence that of that would be increased wear. You get increased stress at the bone implant interface. You can have loosening. You know, if you're out there skiing, you're going off a cliff or something, or, you know, playing athletic sports and contact sports, you could have a dislocation, you could have a periprosthetic fracture, and you just need to, you know, educate your patients that they're at a higher rate of revision. Here's a chart. I know this is a little dated, but it gives you, so we were doing total hips and anterior total hips in 2005. A lot of this stuff is still applicable today. But here is what the trends were in the 1999 versus 2005. That's just a 6-year difference. I'm not sure that's a whole lot different with 2005 to today, but you can see that, you know, they're allowing a lot of sedentary type activities, whether it's cycling, golf, getting back into swimming, doubles tennis, walking, you know, dancing and hiking. And then, you know, you kind of get into this area of no consensus and then not recommended. So, you know, the later studies show basketball, football, jogging, soccer, maybe not recommended, but they are now saying it's okay to do singles tennis. It's okay to go rock climbing and, you know, do gymnastics and things like that. So, you know, I tell patients there's a lot of things they can do. They just need to make sure that they use their cycles wisely and they're not trying to beat on this joint, because the more they do, the more it may wear out. But there's physical and mental health benefits with exercise. I think it's very important. You know, the American College of Sports Medicine recommends 30 minutes of aerobic activity 5 times a week and 25 minutes of vigorous aerobic activity 3 times a week. Driving and back to work with anterior total hips back in 2018, there was a small study that showed 76% of patients were back in 3 weeks, 14% of patients were back to driving in the first week, and most patients were back to work with a mean of 24 days. And obviously it depends on what you do. So we were talking about outcomes of total hips versus total knees. Total hip arthroplasty is one of the most clinically successful and cost-effective interventions in healthcare. Self-reported patient satisfaction is closer to 90%. I think it's maybe even higher than that. Physical function improvement is long lasting. These patients do well over the 25 years or more. A lot of this has to do with how the implant is placed and goes back to the patient's activity level and things like that. There was also, you know, some stuff on the other end of the spectrum where there was a Danish nationwide study that found that 12% of patients within the first year and a half or so were still impaired by chronic pain from total hip. Why would patients have poor outcomes after total hips? And that's very important to recognize as an orthopedic surgeon. Maybe not in other specialties, but things to know about. What if they have positive x-rays? They could be from loosening, whether it's infected or not infected. They could have wear that cause osteolysis or the loss of bone around the cup or around the stem. Patients can get heterotopic ossification. That's something where you get calcification in the soft tissues, and they can build up these massive areas of bone that can impinge and be painful, and can block motion and can just be terrible. Some of that is due to soft tissue trauma and muscle trauma, more common with certain approaches, not necessarily the anterior approach. You can have stress shielding of your implants. That means that the stem is stiffer than your bone, and you can actually lose bone around the stem because of how stiff it is. What if you have negative x-rays? Well, you can have reactive synovitis. You could have something called alval, which is more common in a metal-on-metal hip prosthesis. As some of you may have heard of that. There's a lot of litigation around that. We don't do those anymore. There can be prosthesis impingement, iliopsoas tendonitis, muscle damage, troch bursitis. Troch bursitis after total hip is not uncommon. I see a lot of total hips, usually patients that come in with a painful total hip, and I see that they have been extensively lengthened or given a lot of extra offset. And we'll talk about those on x-ray and how that can cause troch bursitis. Also, again, don't forget lumbar spine disease, nerve problems. Also, it could be hernia or it could be a referred pain. So the anterior approach. So we're kind of going to get in the meat and the potatoes of this thing. Why would we use an anterior approach versus a lateral approach or the age-old posterior approach? Well, anterior approach is minimally invasive. It follows a path between muscles, doesn't actually take down muscles, so it's intermuscular. It's internervous, meaning that there is different nerve supply to the muscles that you're going through, so there's not a risk of you severing that nerve and de-innervating certain muscles. And it really reduces the risk of damage to certain structures, muscles, tendons, vessels, nerves around the joint. So we want to think about patient well-being. We want to decrease post-op pain, increase or keep their muscle tone preservation, which has been shown in a lot of cross-sectional studies, shorter rehab, faster return to daily activities, which leads to all these things to shorter hospital stays and increased patient satisfaction. These are things from an anterior approach that will increase your revenues and healthcare system having sustainability and saving costs. So a history about anterior total hips is first described by a guy named Huter in 1881, and the first total hip through an anterior approach that we know of in 1947. There was a new wave of what we call minimally invasive surgery and a double incision technique in 2003. And then Dr. Laud created this anterior minimally invasive surgery technique in a teaching a program that has led to a lot of anterior approach surgeons in this country that are very well trained. So, you know, total hip, we're talking about what this operation of the century, the best thing in healthcare, but what's wrong with it? You can have soft tissue damage, you can have implants that are malpositioned, you can have leg length discrepancies, you can have dislocations. Well, all these things can lead to muscle degeneration, dislocations, limping, and unsatisfied patients. Well, how do you think we address these things? One, do a better job, put your implants in correctly, or take a guess, the anterior approach. So this is the only approach, again, that follows both an intermuscular and internervous plane. This is a picture from the operating room. That is the size of my incision. It is tiny. So the total hip advantage. So soft tissue damage, we are going to reduce soft tissue damage by going through the intermuscular and internervous path. We're going to try not to damage muscle as much as we can, even though it's a small incision, and then we're going to go through fascial planes and not violate any of this stuff so that we're not getting heterotopic ossification. So we're not having, limps and having to protect people, people having, detaching tendons to get into the joint, leading to poor healing of those structures and those kind of things. Implant malposition, that is huge in other approaches. Other approaches, yes, you can take an X-ray intraoperatively. You also have some instruments to help you guide it, and you use patient position to get it perfect. But I cannot tell you how many times that in residency we would put in anterior lateral hips or posterior hips, and then you get your post-op X-rays and you're like, oh God, that looks terrible. And then your patient does poorly, they dislocate, something like that. With an anterior approach, we use fluoroscopy. I use a 12-inch C-arm and I take X-rays while I'm doing it. That way I know the implants are in exactly where I want them to be. I get their leg lengths perfect, I get their offset perfect, and it's just great. So, we reduce our chance of leg length discrepancy, and by positioning the implants where they should be, we reduce our risk of dislocation. So the anterior approach has been adopted for hip replacement for many years, and it is being increasingly shown in the literature to be excellent. It's muscle sparing, it's patient friendly. There's long-term benefits to this, and it helps with increasing a surgeon practice because people are seeking it out, and it has increased economical benefits for the hospital system. This is, excuse me, that's some good beer. This all should sell a lot of surgeons on the anterior approach. But don't get me wrong, it's hard. Anterior approach is not for everyone. There are certain patients that it is incredibly hard. Very muscular, young patients, males usually that are tight, are very challenging. Obese patients can be challenging and can have wound issues. There are additional costs related to using certain leg positioners or tables. There's a table called a HANA table. Our nice facility up the road, one of our attendees today works at, has a nice table that probably costs about $350,000 to $500,000, depending on when and where they got it from. And that makes it great for doing this surgery. But some of these additional costs are not necessarily need to be incurred by a facility. There's some manufacturers that will bring leg positioners to help you with surgery, and that helps reduce cost. Technically, this surgery is more demanding. Usually that's related to the femoral exposure. I'll show you that here in a second. Again, we are going through an extremely small incision. I usually use my hand, and it is no wider than my 4 fingers. So I wear big gloves, but that's still small. And there's a steep learning curve. This is a very difficult approach to learn. Some people say it takes 100 of these total hips to really learn it and know it well. There are some manufacturers, implant companies that put on courses and send surgeons out to help you, which is extremely helpful as you're learning this. And they'll even come and scrub in with you and walk you through it. It's really great. So what is a real MIS surgery, minimally invasive surgery? So it is to maximize your soft tissue preservation, not cutting muscles, not cutting tendons. The claims to fame for MIS surgery: significantly shortened rehabilitation, faster return to daily activities, decreased post-op pain, immediate post-op muscle tone preservation, less blood loss, shorter hospital stays, cosmetic appeals, and economic benefits. So it's obvious that the advantages of this approach to hip arthroplasty are real. MIS surgery, the advantages, whether it's hip, knee, anything, are real. And it's not just a hoax or some marketing scheme. It is, you see these patients, we can ask Dr. Downs, we can ask another physician here that had an anterior hip, how their recovery was. I guarantee you, they will all tell you they did excellent and fast. There's even a risk of reduced dislocation with an anterior hip, and that lets me sleep easier at night. So no additional costs, the economic benefit, unless you're buying HANA tables left and right. Typically an anterior hip doesn't cost the system any additional money. There's a lot of companies that provide education. Again, like we talked about, they often will, implant manufacturers will bring certain instruments to the operating room free of charge, so you put in their implants. So that's nice. Again, the shorter hospital stays, rehab time, all of that can be economic savings. And also an anterior approach is very efficient in the OR. This is a tiny incision and you don't really need a whole lot of help. I mean, not that I actually need it. They make things that'll actually hold the retractors where you don't have to have a person do it, but I can do this surgery with 1 assistant just as easy as someone can do a posterior hip with 2 assistants or 3 sometimes. And it's an excellent marketing tool because people are looking for it. So some of the stuff we already just talked about, it's high value for the patient, it's high value for the hospital. So now time for some pictures. The Huter approach, anterior lateral or more anterior approach, is a supine position. You don't have to put people lateral, which can decrease a lot of the pressure point issues that come from positioning during potentially long surgeries. Again, very small incision. There is a vertical incision, which I mostly use, which is in that left panel. Again, this thing is almost no wider than the 4 fingers of your hand. There's also, for the patients that are looking for something even more cosmetic, a horizontal incision, or what we call the bikini incision, and that'll lay right in the crease. And so for women that still want to wear bikinis and things like that, especially in the younger crowd, does have appeal as well. So our intermuscular plane, we talked about how this intermuscular and internervous, you are going through TFL and sartorius up there proximally, and that is between superior gluteal nerve and your femoral nerve. You want to avoid your lateral femoral cutaneous nerve. When I first started doing this surgery, I would say maybe 20% of patients had a little bit of numbness on their thigh. I think as I've been doing a lot more of these, it has decreased significantly. I get that every once in a while, but patients are aware that that could happen, and typically it goes away. So you want to watch out for this nerve. There's a lot of variations to the nerve, as you can see there. And this thing can be tiny. You may not even see it. So it's very important for soft tissue care, and during this dissection, you just want to avoid this as you're coming in. The superior gluteal nerve kind of hits this whole area of muscles in the blue, and the femoral nerve more in the green, and we're going to go right between those. So we try not to damage that. Some of your vessels that surround the neck and head, I mean, not a big deal for total hip replacement because we're taking the head out, but these are areas you need to watch out for extensive bleeding, and using cautery in these areas to keep your bleeding down as you go down layer by layer. Capsular structures are extremely important in the stability of the hip, and that is something we'll get to here. You want to preserve the capsule if at all possible. Here's the approach. You're coming through between TFL and sartorius. You go around rectus and then down into the hip capsule. So it kind of looks like a zigzaggy thing, but actually once you get it down, it's very straightforward, very easy. You split this fascia. Here's your fascia here on the right panel. Underneath, you see your TFL. We're going to move these things out of the way. You're going to go down one level. Then you see your white, red, yellow. This is your rectus femoris. You're going to release some of this tissue, and then you're going to get down kind of to a capsular layer. But first you identify this precapsular fat. In this precapsular fat, there's some medial to lateral running vessels that you have to be very, very cautious that you don't get into and get extensive bleeding. So here we slip a little clamp underneath them. We tie them off. I usually tie them off with sutures and then coagulate them in a number of different ways. Then you remove your precapsular fat, and then you are right at capsule. You're in this approach, you can really protect your femoral bundle. And so the risk of nerve damage with this is very low. I typically do this inverted triangle capsulotomy, which opens us up and brings us right into the hip joint. And then we can place retractors on this reflected area of capsule to show us what we need to show. So there you are, you got this triangular laterally based flap that we open, and then we are gonna make our neck cut. And, we use certain things, your linea intertrochantera, your superior border of the trochanter, and your greater trochanteric tubercle to kind of guide our cut. And once, these are some more pictures for you. I know we're kind of running late. You can extensile, you can extend this anterior approach incision to expose the pelvis. You can go down, you can even expose around the back. So that it's a very versatile, actually, incision that you can use. Here's some of the extensile stuff. Here's some pictures down in. This is a cup that's eroded through the pelvis. And you can see that we can come up and actually retract into the pelvis and see into the pelvis to see that cup. And then we can revise the cup, put bone graft behind it, and make that better all through an anterior approach. There's also an extensile lateral approach that you can drop down laterally and down the femur. If you were to have a femur fracture in the OR, you could drop this incision down and plate the femur if needed. So now it's for some fun x-rays. This is one of my patients. She's in her 70s, and her hip is terrible on the left. This lady walks like she just got off a horse. She can hardly move her hip at all. You can also see that she's got extensive arthritis on the right side. We went in, did an anterior approach hip on her, and here's her hip. This lady has high offset, meaning that she's got her lesser trochanters are very far away from her pelvis. She's got a lot of tension on her abductors, and this is something to recognize prior to surgery. This is what's called a dual mobility hip. And so it's got a ball inside of a ball. It's a very, very stable hip prosthesis. Excellent x-rays. Here's another guy. This guy's about 6'6" and 250 pounds, pure muscle. He has a very varus, short neck femur. This is a extremely hard total hip. He's got low offset, all these things. very hard. He took the biggest size femoral stem. You can see from this, I added a little bit of offset to him, but that gave us excellent stability. This is a really good hip. Here's another patient that was sent to me, bilateral AVN. He's collapsed on both sides, and he got 2. This guy went home 3 hours after surgery, both times. He's doing great. Here's another more straightforward total hip. You can see on the right side, she's bone on bone. She's got excessive osteophyte formation, some subchondral cyst formation. This is a very arthritic hip. And she got a real nice low offset type of hip with a large head, very stable. And that's it. So there's some antibiotic prophylaxis stuff. I don't think we really need to go through that. Blood loss, I'm using TXA, something that helps us reduce blood loss by up to 25%. No real increase in DVT formation. I will not use this if they have significant cardiac or clotting history. If they do have that, sometimes I'll use a topical form of that. Pain control, again, there's downsides to narcotic meds, nausea, vomiting, constipation, addictive stuff. A lot of these patients, I'm using just Tylenol, ibuprofen, sometimes some tramadol. Also using periarticular injections with Exparil, which is a long-acting lipid emulsified bupivacaine, and certain nerve blocks to really help get these patients feeling good fast and getting them out of the hospital. I use aspirin for my DVT prophylaxis unless they have significant risk factors. Then I'll use Eliquis or Xarelto. And patients, again, remember that a lot of this is about expectations. I tell people they're going home same day or next day, depending on what I feel like their expectations will be. And typically people, unless they have major medical issues, are home when I expect them to be. Outpatient surgery is an up and coming thing. It's very financially tempting for a lot of these surgery centers and hospitals. It is rising every year, rising in my practice, rising in some of my partners' practice and colleagues' practice. My perfect candidate's a young male with no medical comorbidities and a lot of social support at home and maybe a ranch style house. Here's my wife and my kids. I am very blessed. Thank you guys for listening. Let's get into some questions, and also let's talk with Dr. Sana here.
All right, man. Thanks for that talk. Now we're going to have Dr. Sana, who will present on hip or imaging of hip arthritis. Dr. Sana is a board certified MSK radiologist with Colorado Imaging Associates. He specializes in sports med, orthopedic oncology, and spine imaging. He's worked with multiple collegiate and professional sports teams that include the LA Lakers, the Chicago Fire, which is one of the MLS teams, as well as the UCLA Collegiate Athletics. He's also been a large part to some of the significant improvements through health imaging with a lot of our imaging. He's really kind of spearheaded the improvement of certain MRI sequences and whatnot to really give us some excellent imaging that he's now become my go-to for essentially anybody I have a question for. So Dr. Sana, we'll let you take over.
Hey, thanks for the intro. It was a great talk, Dr. Noel. I'm just going to share my screen here. All right, everyone see that? Can everyone see that?
Yep, I can see it.
All right, cool. So I get the amazing honor of talking about arthritis, specifically hip arthritis, super sexy topic, but I'll try and make this interesting. You know, I know we're running a little late, so I'll just try to brush over some of the stuff that Dr. Noel covered in his talk. So, you know, let's see. So the learning objectives are to just understand hip anatomy. I think Dr. Noel went over that pretty well. What to order for hip pain and hip arthritis specifically and why. I'm going to stick to x-rays here. I'll touch on MR a little bit and then talk about the common mistakes and misconceptions with hip imaging. You know, ordering imaging is one of those things where whenever you get out of training, you're expected to just hit the ground running, but there's really no formal training on what to order, why, and how. So hopefully this can at least clear up some of that stuff in the narrow field of hip arthritis. So let's just go over some anatomy, but basically the reason I have this slide is to just drill home that arthritis is essentially a problem of the cartilage. So whatever other structures are here, the bone, the labrum, the capsule, those all get dinged up because the cartilage is gone. If the cartilage was intact, you wouldn't have any of those subchondral cysts, any of that reactive marrow edema, you wouldn't have synovitis, you wouldn't have any of that. It's all because of this articular cartilage of the femoral head and along the acetabulum are screwed up. So this is what a normal hip x-ray looks like. The stuff that I look for, and one of my biggest pet peeves is people kind of just always kind of sidebar me and they say, hey, can you just teach me how to read a chest x-ray, or can you just teach me how to read like this x-ray or that, and I'm always like, I went to a 6-year residency and fellowship for that, right? Like, I don't really go to your job and say, hey, can you just teach me how to do your job in like 10 minutes? So I can show you what I look for, but to actually kind of really read these, it's tough because there's just too much. But basically what I look for is I look for joint space narrowing. It's almost always superior. If it ever goes superomedial, we can call that axial. I kind of think of an inflammatory arthritis. I look if there's any marginal osteophytes. Basically with arthritis, the cartilage just gets broken down and the joint just feels unstable. And so how does it correct that? The only way it knows how, which is just to lay down more bone to try and fix that instability. And so that's why you get these marginal osteophytes. And then the cysts kind of form whenever the bone starts pushing that joint fluid through, the other structures start pushing the joint fluid through the bone because the cartilage is gone and you get those cysts. What do I order? I order exactly what Dr. Noel does, or this is what I recommend, is an AP pelvis, an AP of the affected hip, and then a frog leg lateral of the affected hip. And I'll get into why, but let's start with the AP pelvis. So there's all sorts of different morphologies that your hip can have just congenitally. So your hip can be retroverted, meaning that the cup part of the joint is just hanging over posterior a little too much, and you'll get this kind of crossover sign of the bone. It can be too deep where there's just some over coverage laterally, and that can cause issues. This is another type of just really deep socket called protrusio, where the head projects more medial than that ischiofemoral line. And then you can even have, on the other end of the spectrum, dysplasia of the hip, where it's just too shallow. And all of those things can cause different mechanical issues. But at the end of the day, what they all lead to is arthritis. Arthritis is kind of the end game of most musculoskeletal processes. Whether you ding up the cartilage, the labrum, you fracture, whatever, eventually you end up with arthritis. And so that's what we're trying to prevent. So by identifying these subtle findings on the x-ray. So, okay. So the reason that I get the AP pelvis and I can't just get away with that single small field of view AP hip is because the measurements change. The x-ray is not a real spatial representation of that joint. The x-ray can look differently depending on where the camera tube is, if you're angled too down or if you're angled too high. And so that small field of view of the hip is going to change a lot of these measurements that I do. So I know I'm only showing you the small field of view here, but all of these measurements are taken on the large field of view AP pelvis. That's the only reliable way to tell if the acetabulum is too shallow or too deep. So this is an example of a really shallow hip. And so this is from developmental dysplasia. So basically your hip socket deepens as you age when you start putting weight on it. So if a child just doesn't really weight bear, if they have cerebral palsy or whatever, they will end up with developmental dysplasia of the hip. And it can happen for other reasons as well, but that's typically the most common cause, is that they just don't bear weight on their hips, so they never deepen and develop. The AP view is really just to give me a nice kind of close-up view of that hip. It's really hard to catch subtle findings on that large view of the pelvis. That's mostly to look at the contralateral hip. Some processes are bilateral, so that helps me. But this is where I go to really evaluate, okay, how severe is the arthritis? Is there a fracture, et cetera? So this sclerotic line here is a pretty subtle stress fracture. So there's just compression of the trabeculae, which forms a sclerotic line. There's no cortical disruption, but it's a stress fracture, and that can be hard to see on that larger field of view of the pelvis. This is just an example of some pretty bad hip OA, and I just get a way better look at it on this small field of view than I do with the bigger one. So the frog leg lateral, it's also sometimes called a Dunn lateral view. Basically, the reason I get this is, well, there's a couple different reasons. This is probably the most common reason in a young patient. I'm looking for something called a CAM lesion on the hip. So there's different types of FAI, or femoroacetabular impingement. And one of them, the most common, is something called a CAM deformity, where the femoral head is not completely round. It has this kind of bony bump on the anterior superior aspect. This is an MRI kind of showing you a more exaggerated CAM deformity. So you can imagine that whenever this hip goes into flexion, this bump bangs up on that acetabulum and tears the labrum. And so that's why this frog leg is so important, at least in young patients, is to help me identify that CAM deformity. This is a post-operative picture where it shows that the surgeon went in and did something called an osteochondroplasty, where they shaved that bump down. So the other reason to get this frog leg view is not infrequently, the earliest sign of osteonecrosis can only be seen on this frog leg view, and it's this really subtle linear lucency in the subchondral bone. And you can only see it on this one view, and this is the time to catch it, because if you have osteonecrosis and you catch it at this stage before the articular surface collapses, then the surgeon can go in there, they can drill, they can decompress that, and hopefully that subchondral bone plate doesn't collapse. If you don't catch it in time, then you get something that looks like this. And so this femoral head is essentially avascular, it's sclerotic, it's got a bunch of lytic and sclerotic areas, and this will progress to osteoarthritis because the subchondral bone plate collapses, and then you get an irregular cartilaginous surface, and then that grinds away at the acetabular cartilage, and you just end up with OA. So let's talk about kind of the common mistakes I see. So this happens in the knee all the time too, where I'll get an order for an MRI and it'll say rule out labral tear. And I'll look at the X-ray and I'll say, well, that's dumb, because I can tell you just by looking at the X-ray that the labrum's torn. And that's because they have really bad arthritis. So again, if you just go back to the anatomy, once this cartilage is gone, there's nothing for that bone to bump up against you except for the labrum. So that labrum is going to get chewed up. As soon as you have arthritis, that labrum's toast. And a surgeon can go in and they could theoretically repair that labrum, fix it, tack it down, but it doesn't matter because there's still this uncovered bone with all of these marginal osteophytes that are just going to chew up that labrum again. So if somebody has really bad arthritis, you can just assume that their menisci are torn in the knee or that their labrum are torn in the hip. There's no need to waste their time and their money getting an MRI when I could tell you that from an X-ray. Again, the arthritis is kind of the end stage for a lot of musculoskeletal problems. And that's why we try and fix the labrum early, or fix the tendons or the cartilage early before they end up looking like this. So another kind of common mistake is people ordering imaging for septic arthritis. So typically for any infection, the best test is an MRI with and without contrast. In most cases, I would say 99% of cases, that's correct. And so the patient will have a prior MRI, or they'll have some other imaging, and they don't have a joint effusion. And I still get an imaging order for, hey, can you rule out septic arthritis? Well, the thing about septic arthritis is that if you don't have a joint effusion, it essentially excludes it. I mean, I can't sit here and say 100% because nothing's 100%, but at the end of the day, I'd be willing to bet a lot that if you don't have a joint effusion, you don't have septic arthritis. So if you have a non-contrast MRI already, there's no need to get a pre and post contrast MRI. There's no need to ask me to tap that joint. There's nothing to tap. There's no fluid. It's just not infected. This is what a classic septic arthritis looks like. There's a massive joint effusion here, which is that white fluid, and then there's bone marrow edema on both sides of the joint. This is a normal looking joint. That's a physiologic amount of fluid. I would dictate this as, unlikely to have a septic joint, right? There's no synovitis or any soft tissue swelling around it. When these joints get infected, they're angry. They produce a lot of edema. If the bone marrow is not edematous, then usually the pericapsular soft tissues are edematous. So this is an example of a more subtle early septic joint. So they don't have a large joint effusion, but they definitely have some pericapsular soft tissue edema. So septic arthritis, if they don't have an effusion, they don't have a septic joint. And then lastly, I just wanted to talk about, we see so many things on imaging that, I'll comment on, oh, there's this, the patient has a little bit of this, a little bit of that, or, oh, they have some bony irregularity here. And then I'll try and put in the report sometimes, oh, like correlate clinically, right? Like it's always a cop out that radiologists say, but it's really true, because if I say, oh, they have a little bit of this, or they have something right in this location, but the patient doesn't have any pain there, then it doesn't matter. Like it's not worth chasing. And so to give you an example, there was a recent study of 2,000 asymptomatic patients that was done. 37% of them had a cam deformity, that big bony bump. 67% had a pincer deformity, which is acetabular overcoverage, which is a different type of abnormality that predisposes to impingement. And 68% of them had labral tears, but they're all asymptomatic. So just because I call a labral tear, in a hip, it doesn't mean that that's what's causing the patient's pain. You really do have to treat the patient, not the imaging. And then specifically to hip arthritis, I've seen people who have hips that look like this. I mean, it's not that bad. Maybe there's some mild joint space narrowing there. There's really not much marginal osteophyte formation, and they're in severe pain. And their x-rays don't look that bad, but these people get a total hip replacement, and it has nothing to do with the x-ray. It's the pain. And in my mind, and maybe Dr. Noel can comment on this, for people who get joint replacements, the number one goal is to solve their pain. If they have pain that's interfering with their life, if it wakes them up at night, those are the people who need surgery. Its function is almost secondary. And so people are super happy with total hips because we've gotten really good at them, anterior hip approach, and just other advancements in total hips. And their function is right up there with their pain relief. But other joints, with elbows, for example, like our elbow implants are just not there. But if it takes the pain away, that's the number one goal. So this patient they could have a hip that looks like this and have absolutely no pain, or they could have a hip that looks like this and they could be in pain that wakes them up at night. And this guy gets replaced and this person's just walking around with no issues. So basically treat the patient, not the imaging. I kind of shown you a few examples of what I look for with hip arthritis and a few pitfalls. Ordering imaging is pretty complex. So me and a few of my friends, we built this radiology app called RADS Consult to help clinicians order imaging correctly. I mean, there's over 500 different types of, CT and MRI you can order. There's a million different caveats and indications. And it was mostly just a big pain point for me. I just get the same phone calls every day. Like, hey, what do I order for this? What do I order for this? And I'm like, there's got to be a better way. So if you go to the Apple or Android App Store, I don't want to charge anyone for this. I would happily give it away for free forever, but Apple only allows me to give 1 year free subscriptions. So if you screenshot this or write this down, you'll get prompted 1 month after you download the app, and you just put in this promo code and you'll get it for free. But basically you can type in any symptom or diagnosis. You can type in hip arthritis, you can type in hip pain, and it'll tell you exactly what to order. You can type in septic joint, with or without contrast. And there's a lot more there, but hopefully this will help you guys out and me out as well, down the line. So that's kind of, it's my super short talk on hip arthritis. And I did want to pull up, there was, I think, an X-ray that somebody did. So you guys see this?
Yeah.
Oh, okay, hold on. Sorry, I think oh, here we go. Okay, can you guys see that?
There you go.
Okay, so I guess somebody uploaded this case they want to look at. So obviously this femoral head is completely gone. The acetabulum's really remodeled. It looks like there's periarticular osteopenia of whatever's left. And so this is called rapidly progressive osteoarthritis. It's a little bit of a misnomer because it's kind of a junk term. We don't really know what causes this. It's just some insult, whether you get a subchondral fracture, whether you get, you just tear your labrum, or you get too many hip injections, or you get something that happens and it starts this cascade event of inflammatory cytokines, inflammatory response, and you get massive chondrolysis and you get massive bone resorption. And so, there's a few other things that honestly, this is a differential, but that's the most common cause of what this is it's just called rapidly progressive osteoarthritis or rapidly progressive chondrolysis. But the full differential includes something called Gorham-Stout disease. It's like vanishing bone disease, also another kind of weird process that we don't really know what causes it. They could have had a fracture, and so fractures can cause a big hyperemic reaction and cause bony resorption. They could have had AVN. They could have had just some big inflammatory insult leading to bone resorption. That's kind of the underlying cause. But either way, this guy's getting a hip replacement. So,
and I think that also points out the importance of, it helps the radiologist to give some sort of history so they know what to look for and what to actually include in the differential diagnosis. Because if that patient comes in, they say they're in a car accident a month ago, they're in the hospital with a hip fracture, that changes, I would imagine, what you're going to read versus if that's actually an asymptomatic hip.
Yeah, absolutely.
Yeah, every time I order an MRI, a CT that I send over to Dr. Sana Health Images, I always put in the comments what I'm thinking. I put medial joint line pain, rule out meniscus tear, history of this and that. I mean, I think if you just add that little bit to your order, as long as that order is being transferred to them, it's going to help Dr. Sana and his fellow radiologists really kind of pinpoint and give you a better idea, a better read, and help their job and help you get a better result.
Yeah, because I always put on their back pain and that's it. So
Well, that would be typical of someone like you.
So the kind of bad part about that is that I love those rule out indications, but CMS won't reimburse radiology for rule out this or that. They need an actual symptom, not a diagnosis. So they need back pain. Well, I need back pain so I can get reimbursed instead of rule out disc herniation. But I always love it when you guys put that in there along with something to just check those, you know.
so, I mean, yeah, I should say like L3 radiculopathy and back pain is what it should say, not rule out. Like,
Yeah, don't put rule out, but I usually put in the diagnosis, you know, whether it's knee pain or whatever, meniscus tear or hip pain or labral tear, and then in the comments try to put what you're thinking.
Yeah, I mean, for like back pain, neck pain especially, you gotta tell me whether they have right-sided or left-sided symptoms or no radiculopathy. Again, people, I mean, everyone has all these tiny little disc herniations, a little bit of facet arthritis, a little bit of this, a little bit of that. But if their pain's all on the right side, who cares what their disc herniations on the left side are looking like?
Yep, I agree. So then, Dr. Sana, does Health Images, they offer MSK ultrasound, correct?
They do. It is limited in the locations that they offer it at, and it's mostly just because the ultrasound techs are not trained to do MSK. It's pretty it's an additional special certification, and there's not that many techs you know, in Denver that even have that. So we do have it. I believe it's in Cherry Creek.
Yeah, this is Lauren. Sorry, I'm just answering for you. We have MSK ultrasound at our Cherry Creek and our Longmont location, foot, ankle, hand, and wrist.
Okay. Now, I would throw out there that from the orthopedic side, that MSK ultrasound is typically not something I ever really hinge any diagnoses off of. They're going to end up getting an MRI anyways. It should be, in my opinion, something that's recommended by radiology. Hey, it'd be helpful to have this. But I certainly think if somebody has like a muscle problem, I'd be more worried about, if I'm worried that they have pain in their thigh, getting an MRI to rule out like a myosarcoma or a large hematoma, you know, things like that. So MSK ultrasound doesn't really help us very often.
Yeah, I mean, and it's pretty targeted too. There's only, I mean, the MRI shows you pretty much everything. You know, MSK ultrasound is very targeted, and in an ideal world, I would have the time to go in there and scan myself, but you know, we're relying on techs. You're not sure, you know, what they're going to see. I know that the radiologists, when we do have MSK ultrasound available, those radiologists do go in and scan if there's ever a question of what they see on their images. But still, it's from a practical workflow standpoint. I mean, MR patients in, they're out, you know, it's faster for them and it's more definitive.
Very good. I agree. All right. So I'm going to start wrapping it up. I'd like to thank everybody for joining us tonight. I hope everybody enjoyed the lecture, the beer, the wine, and the snacks. Thanks, Dr. Sana, for joining us and telling us all the stuff we need to know, because, you know, it's sad that I look at imaging all day long and there's still stuff every time a radiologist shows me something that I pick up another tip and I'm like, yeah, I don't know why I didn't know that. Kind of embarrassing. And thanks, Dr. Noel, for your talk on anterior total hips for hip arthritis. So everybody get your pens ready, because I got your CME number, and I know Karen will probably be sending out the email tomorrow, but to claim your CME, the code is, I'm going to read it one time, 844-2021-11B. And the deadline is Friday, December 10th. So you have a month. If you're having any problems, contact Karen Johnson. She'll be able to help you. And that site that we go through is www.yourcesource.org. So yourcesource.org. As you guys know, I kind of said at the beginning, this is our last lecture of the year. We're planning on offering 6 more lectures next year that'll start in 2022. I'd like to know, and the surgeons and providers here would like to know what interests people. So please let us know what you guys are interested in. We'd like to formulate these, not for what we want to talk about, but what you guys want to know about. It's a good thing for us to also look at what the education deficiencies are in the community. So contact Karen. Early next year, she'll be sending out our 2022 schedule, and she's included her email right here for everybody to send her an email if needed. Take a picture of your phone, because that's also where you can give us topics. So our first lecture next year will be Dr. Schnell, and he'll present that. We're tentatively planning on February, but that may change a little bit. Again, I'd like to thank all the participants for tonight's program, and everybody for giving these wonderful talks. It's been fun for me, and it's been a fun year. I'd also like to thank our co-sponsors, Health Images, because they've actually done a pretty huge amount of work behind the scenes. You guys get to see our unattractive faces, but the real workhorse behind this has been Health Images, and they're getting us the CME so that we can do this and make it worth everybody's time, because free alcohol is not worth everybody's time. I'd specifically like to thank their education director, Katie Black, their local representative. I'm going to screw up Jenna's name, but it's Gouge. Well, it's spelled gorgeous, Gourgues, but it's like French, just like Dr. Noel's residency, De Pere. She delivered a lot of the refreshments and things for you guys. And without her, quite honestly, we wouldn't have been able to get this stuff to you. I hope that everybody enjoys the rest of their evening, because there's not much of your evening left, because we all got to get up early tomorrow. And we look forward to seeing you guys next year. And that's a wrap.
Thanks, guys.
Thank you.